run an interview with a patient. These are models. It means that they are ready plans. They are not being placed there by people just thinking about them. يعني هر أوانية بيروكي كسيك بيا جمارة كسبيو ولن ولا أو بيروكي باش ديارة بابيكينا موديلك بو consultation. چوني بينينيو قصكرد لقل نخوشو مقابلين نخوش. No. They are actually results of studies. These studies, some of them have been carried on over 20 years, some of them even longer, some of them a little shorter. And most of them have been carried internationally or over a few countries, mostly the Western countries. So they are the result of, the studies of experience of, for example, GPs mostly, and also people in other specialties. The result of those studies have been evaluated, analyzed, calculated and analyzed using statistical values and some other programs and some logical discussion and things like that, and based on previous experience, and then they have been published. After their acceptance in publications and after they are reviewed by different medical councils in the UK, in the US, by the World Health Organizations, then they are adopted. Right. So they are adopted then internationally or nationally or over some few countries to be used. They are plans, ready plans to follow a consultation. How to run the interview, how to talk to the patient, how to finish the interview, and what to do in between. But they are not, as I'm going to explain to you, they are not plans to be strictly followed all the times. You can follow it. You can use a combination of different programs. You can change them. It's too early for your stage to be thinking about consultation models, but I think their presence here is just to give you ideas, just to give you what are the planned ways of seeing a patient. So it's like going through over most of the things that you have studied so far in the previous sessions of this module, going through them again within these plans. So the idea is to be familiar with most or the most famous of these models, and to discuss and to be able to see what is the special point of each, how to differentiate between them, and what are the strong and the weak points of each, and also to provide ideas to how to build a consultation model that best fits you in whatever specialty you're taking in the future. So as I said, the idea is, because consultation is at the heart of the medical practice. When the consultation, when the interview with the patient goes fine, especially the first one is very important, then things will go most likely very smoothly after that. So it helps like anything else in the world. Like even if you are making a salad, okay, or cooking something, or giving a lecture, anything in the world, if you come planned, it will make things easier for you and whoever you're doing that thing for. It is also good in time-wise, because you are going to be in much better control over the time. In this case, your time as a doctor and the patient time. And also, also, it's an effective use of resources, because if you have good plans, then you might not repeat some tests unnecessarily, okay? And as a result is, it's the best outcome for the patient and the doctor. So before we go to the models, we need to go through the traditional medical consultation model. The traditional means the things which do not fall into the models which I'm going to explain. And some of them which are going to be explained next week. This is the traditional way, the way which is done traditionally without much studies and basically just been going on with experience. This traditional method is still being carried on here, but it's not being carried on in the Western countries, in fact, since the 70s or the 60s. But just because we call it traditional and old, it doesn't mean everything about it is wrong. That's not what I'm trying to do here. However, it's only to show why were they need for development, for improving things. So you've been through this already. We've been discussing this in the other sessions already. So the traditional method concentrates on diagnosis. That's not a bad thing. However, diagnosis itself can go wrong if the interview is not done properly. I always say this to the groups that I have the study sessions with. You are not asked or told that listening to patients is important only to make the patient feel better. No, that's a very wrong idea. And I have feeling that some of the doctors have this idea as well, that communication skills module is for that. That is one of the, that's one of the goals. But the main goal the most important goal is that you want to get to a better diagnosis. Because at the end of the day, with all your experience and your knowledge, the data, the facts, the information you are getting from the patient. Okay? You might get to know new symptoms for a certain disease that were not known before. So you need to listen to that patient. This patient might give you an idea of a new symptom or a group of new symptoms that were not known before. And a very good example, in the case of the pandemic in COVID-19, there were a large group of symptoms reported and reported in studies and published. Why? Because doctors in the Western world, they listen to patients, and in some other countries as well. And they were not dismissive. So any patient telling them that they have a pain in their leg when they're vaccinated or with the infection, they were not saying, oh, this has nothing to do with the infection. They actually investigated it, and in many cases those symptoms were shown to be related. Anyway, so the traditional method does not consider, in addition to getting to proper diagnosis, you need to listen to the patient. It also does not consider the thoughts and the feelings of the patient, which are also related to diagnosis, but also related to the patient being, making the patient to trust you as a doctor. So in other words, I think you've already been, the difference between illness, disease and sickness is being explained to you. So it's not interested in the illness, which is the patient's view and feeling of the sickness or whatever they are complaining from. So as a result, it results in mostly dissatisfied doctors and patients, and it's done mostly over too short a time, and there is no reassurance for the patient. So the patient doesn't necessarily feel comfortable all the time. As I said, they're not there to be chosen to say, well, I'm using this model for my specialty and that's it. No, in fact, you can change, as I said. You can make a mixture. It depends on, there are not rules to be followed strictly, but they are there to help you plan, as I said. And most of the time, you will see that there are some things that concentrated on by one model, not concentrated on others. Okay, and a different range can be used. So the models try to ensure more patient involvement. And they have many points in common, and that is that they, the source of information, the patient, the tests, wherever, the information from talking to the patient, the physical examination, the tests, the source of information from the doctor. So to widen that, and also to the information processing. So the processing to be done in discussion with the patient, in discussion sometimes with other doctors. It has to be done in a wide way, and also the output of the result should be explained to the patient one way or another, and should be also, it should take future, what might happen in the future in consideration. So, what you see here is not for you to know by heart. أمانة please ناكل بركان بهيج شوية بلام أواني كباسي أكم ناو كاني بزاننو سبيتان الله لهريكي شي تايبتا بو consultation modela بوي بزانن بوي بيناس نوا باشا. But these boxes here are not for you all to know them all by heart and all that. It doesn't work like that. They are here for you to have an idea of the major consultation models that appeared over the years. The ones, and just because some of them are in the 60s, 70s, 80s, whatever, it doesn't mean they are no longer used. No, that's a mistake. It means they appeared in those years, but many of them, in fact, most of them are still used, but they are improved. People keep using them, doctors use them, and they do studies on them to improve them. So you have a number, Barn and Long, which I'm going to talk about, for example, Stolten Davis today. They appeared in the 60s and the 70s. A group, they have appeared in the 80s, Holman Folk Model, Pendleton, Neighbor, which I'm going to talk about in some details. Some appeared in the 90s, and some appeared after the 2000s. The neuro-linguistic programming, this is mostly used for psychiatry, psychological cases, mostly Barn model, the narrative medicine model, and so on. The first one is the 6 consultation model, it's also called Barn and Long model. So you need to know one of the names at least. So it puts it in phases, what happens with the patient. So talking to the patient, first of all, that's the main idea, is to talk to the patient properly. So the first thing is to establish a relationship, by welcoming, by asking questions, by the verbal, non-verbal communication to make the patient feel comfortable on that. And then the doctor either immediately discovers what is the problem, why the patient is visiting the clinic, or attempts to. It depends on the type of the problem. So sometimes it's easy, it's direct. Sometimes no, it takes some time. It takes some cross-examination with the patient, doing some tests and so on. And then physical or verbal examination, or both. There should be a verbal examination. Sometimes there is no need for physical, sometimes there is need for that as well. And then either the doctor alone, depending on the nature of the problem, or the doctor with the patient, or sometimes, in some cases, it only requires the patient to decide the condition, to decide what plan to go with. And then, to decide what the condition is, what is need to be done, and then to agree on a plan for the treatment, and then to terminate the consultation. Terminate, it doesn't just mean that for the doctor to say it's finished. No, it means summarizing for the patient, telling them what is to be done in the future if there is anything needed to be done, and so on. The expanded model is one which is used for psychosocial concerns, in people in emotional distress, but it doesn't mean it's not used in other specialty. Okay? But it's a model which has two things which are specific about them. دوش تيجز أحمد بدنبن. Right. دوش تي هي كتايبة من دبوي بيناس now. Right. So first of all, before I go to those 2 points, it actually composed of four sections. First one is managing the present problem. What is the problem that the patient is actually visiting the clinic for? And then managing of continuous problem. Is there a chronic disease? Is there a general, lifestyle, health style that needs to be changed and so on? And then there are those 2 points which it concentrates on. The first one is opportunistic health promotion. It means to take the opportunity of the patient's visit to advise them or direct them in their general lifestyle. If they need other tests, for example, if they need some health advice and so on. يعني استغلالي أو أكيد نخوشك هاتو تعيادك دوشتك هاتوا. بلام تو رنجا مثلا كشيكي هي شاي كشيكي هي جوي. بلام أجر هي أبيني بلين لشيو دياركم زور شولنا كابون منا جگرال كشي أشتكي هي ليه برسي خواردن تشونا جولت هي جولت نية خوت شونا إزور شت هي توين ليه برسي لو حالته رنجا بيبلي رنجا لتمنية كابين بيستهني تيستي تربكا أو نهاتوا. So this patient might be required to do other tests not related necessarily to the immediate problem, but this is a good opportunity for the doctor to improve this patient's lifestyle and if they need tests. Whether it's a certain age, they need to do some certain tests, whether it's something that you suspect in the family. Maybe this patient, you know that the other members of family have visited you and they have a risk of a certain condition or a disease. Then you ask them, have you ever done any tests for that thing? Because your family could be at risk, and it's always best if you do the tests in advance. There are some other examples: smoking, excessive alcohol consumption. This is general. People need to ask things like lack of exercise, unhealthy diet, and things like that. It's very important, especially in our society. People have a special respect for doctors, and especially they see a doctor which is really interested in their health and lifestyle, so they listen. They will listen to their advice more than anyone else. The other point in the expanded model is help-seeking behavior. To modify, to change a help-seeking behavior. What is a help-seeking behavior? A help-seeking behavior, it means to have an attitude towards the disease. The patient has an attitude. What sort of attitude? Denial. Ignoring the problem, trying not to face that they have a problem, as a denial. Sometimes it could be embarrassment, shyness. They are too shy to talk about it, too embarrassed. They are not comfortable talking about it. They are too busy. They want to forget about it. All of this comes under the attitude. They have an attitude. They are not taking their condition seriously, or they try to run away from it. So this model tells doctors to be aware of things like that. And they are not often visiting the doctor as often as they should be. They're not taking the medication. They are not taking care of other things like the healthy diet or exercise that must go with that, with that disease, whatever, they must change it. So all of this must be modified, must be changed by the doctor. And it is not easy. The doctor needs to find out, why does this happen? Need to try and find out, why does this happen? If it's a child, they need to ask the adults and also directly the child. And they also need to find a way to persuade the patient to change that behavior. This is a caricature. It's just for, make it a little funny, but it says, this lady here says, I actually, I eat what I want. I diet very well. I diet religiously. I eat what I want, then I pray I don't gain weight. This is just a funny way to say how some people are in denial. You do often hear people saying that I don't eat much. يعني هي أو هي طبعا معناها وين هي حبوكاتها حالتها هرمون تيكتشوا ثايرويد تيكتشوا دكتورة كابي حساباتي أو شتانكا كأو نخوشة أو قصي طواب راسها بلام حالتي زوري شيكا أو كسا راسقونية لقل خوي بونمونا بو مسالي خواردن أوانا نزاني يعني لبيرينية يا اعتراف ناكا لقل خوي داني بينانا لنيواني وجبة كان چن يشتيت الأخوة يعني چن يكم جولاكا إنت أو شتانا so the doctor needs to find the right way. So you can't, of course, as a doctor, say you are lying. It doesn't work like that. But you have to find a way. Okay, so an example, if a lady, a 70-year-old lady, she's got a DM and she's got arthritis, and she has sent her daughter for the doctor. She has missed some appointments, but then she sends her daughter for some prescription, repeat of prescription. Then as a doctor, you have to consider many things. In this model, you have to, well, first of all, you concentrate on the present problem, which is the repeat of prescription. You have to decide whether they need it and, to provide it, of course, it has to be done. And then, is there a continuous problem in general? Well, she's maybe asked for things for her arthritis, but you need to consider what she's suffering on in the case of DM and any other problems she might have. So in this case, Biz Ahmed, stop talking. Right. So here there is a behavior, and this lady is not visiting, is not going to the appointment that the doctor has put for her. So this has to be changed. The doctor can talk first of all to the daughter to see what is the problem. Is there negligence from the old lady herself? Is it because she cannot find any member of her family to have enough time to bring her to the appointment? So is she being neglected? Whatever. So they need to find out. Also, what are the health promotion, opportunistic health promotion here? There are many things, because in that age, you have to check, you have to consider for her to test for hearing, for vision, for renal diseases, cognitive impairment, some vaccines she might be reliable to take, maybe she make her life better, and so on. Another model, a third model, is Holman Folk model. This is one which focuses much on the patient's perspective. So, in other words, it requires the doctor to put themselves in the patient's shoes. It requires the doctor to think and to imagine what will go into your mind if you are the patient. چی لمش كتراتبي أجر تو كدكتورة لجي أو نخوشبي بزاني فلان نخوشي هيا. چی پرسیارك لمش كتراتبي شون بو چی جورا دلناكي درستبي. Are you gonna be worried? Are you gonna be so? It depends. It focuses on empathy a lot with the patient. It doesn't mean the other models doesn't care about empathy. It means this one focuses on this thing more. And it gives you example of how to talk to the patients. And for example, you say, I can understand, I can try to understand and feel how frustrated you are. Of course, if it is something serious, you can't tell them this if they have only the flu. Yeah, I can understand you are frustrated. But if it's something serious, it helps the patient to understand that the doctor actually is does feel for them, so they will listen better. Okay. The disease illness model is a more patient-centered interview. So there are two approaches that the doctor needs to use together. The patient experience of the illness and also traditional consultation, taking history, recording the thoughts that comes to the doctor for the possible diagnosis. So it helps realize that disease is the cause of the sickness. So illness so this is the disease. Illness is the experience of the patient. So in other words, this model is the one that focuses between the difference between the disease and the illness. In other words, yes, you might diagnose a disease as a doctor, but you also must know how this disease makes the patient feel, physically and mentally. You're not required to learn these by heart. This is only to know the plans. It only says that the doctor must think in two ways: taking records, taking the history, try to reach for a proper diagnosis, for the proper plan, but in the same time to be aware of the ideas and thoughts and fears and worriness of the patient and how did the disease affect their lives, and to join all of it together. So again, the feeling is really important. Here's two people who found out that undiscovered differences between the health belief of the patient and the doctor can lead to problems in patients' satisfaction, compliance, and outcome. So if they think the doctor is not interested in how much the disease is affecting them, if they have their own thoughts and they think their doctor is not listening, again, we have repeated this many times, it leads to, most of the time at least, to unsatisfied patient and patient who's not going according to the, based on the doctor's plan, treatment plan. This is just one example. Here in emergency, there are a third of emergency patients, I think this was in the US, sorry, I should have written the source of the information. So when they go with chest pain to emergency, they've been found that they have psychiatric disorders as well. So here is an example. When we are talking about the illness and the disease, so they have chest pain. But it is actually, if you listen to the patient, you will find out something that helps you in the diagnosis. As I said, it's not just to make the patient feel better. So here, it's been found it's related to psychiatric disorder. Okay. Another model, the 7-task model, or also called Pendleton. It puts 5 tasks in one place and 2 tasks together. بزحمة شن جابلين بيدنبن يعني أم ساعتين أتوان توزي بيدنبن. So 5 tasks concerned with the doctor, what the doctor needs to achieve in diagnosis, in treatment plan, and so on, and 2 to deal with the use of time and resources. So مثلا أبغى ديالا تركيزة كاتا سر شتيكتر جيكا لها مخالة كان يتري تركيزة كاتا سر أوي أقداري كاتبة أقداري resources با أو مواداني أو شتاني أو جهودي خود كبكارديني. So it shouldn't be too short, but it shouldn't be too long. And the resources you should use the resources, including your own efforts, only as much as possible, but not less, but not more also. Some questions to include to build a better relationship with the patient in this model include, was there anything else you were hoping to discuss today after you've discussed the main thing? You ask the question, such questions, so that you help the patient to remember if they have other health problems or if they have other symptoms, and to tell you about their lifestyle, whether this lifestyle goes with the treatment plan. Or things like, what is your main fear? What is your main concern about this problem? And were you hoping to get, what were you hoping to get out of this visit today? So you listen to them, you summarize to them, then you ask them such questions so that you're also aware of the patient. And also it helps you to plan better for future appointments, if there are needs for future appointments. Again, you're not required to learn this by heart at all. This is only, putting these points in more detail so that you have a better understanding of them. It doesn't work like that. You only need to know what is special about each consultation model, but here it helps you. For example, the first task is understanding the reason for the patient's attendance. So patient, what is the problem? What is the history? What's the effect? What's the patient perspective? How does it affect their lives? What is their health values, ideas, and so on. And so on when you go with the other task. So the second task is achieve a shared understanding of the nature of the problem. So you need the patient to understand what's happening. You need to explain your diagnosis. I think this is my diagnosis. Based on this. You explain them. Of course, you explain based on the level of understanding of the patient. Okay? But you need to explain. You also need to explain the treatment. Whatever. You need to explain the tests. You can't just tell them, go and do that test. You have to tell them, we need to do this test because it will tell you this and that. You need to take this medication. This medication is this and that. It's concerned with this and it has such side effects, and you need to take it before meal or after meal because of this. Okay? Everything needs to be explained. Okay? So other things like enable the patient to manage the problem, to help you manage the problem. If there is a need, for example, and change in the lifestyle, consider other problems. Again, so this is like taking the opportunity of the patient's visit and use time appropriately and resources appropriately. This is really important, as I said. The inner consultation, also called neighbor consultation model. Here, it has the same things repeated, like establish a working rapport with the patient and to check, to summarize. Summarize is really important. In all the models is important. So once you listen, you ask questions to the patient, then you summarize. Once they finished, you say, I think from what I understood, your complaint is this and this and that. Okay, is that right? Have I forgotten anything? If they agree with you, then you say, I think then we need to do such and such test. Or sometimes, if it's simple, you can say, well, I think the diagnosis is this. I think you should try, and I'm going to write this medication for you. Handover is make sure the patient is happy and agreeing with the management, with the treatment plan. But there are two particular points here that are focused on by this model, which is safety net and housekeeping. Safety net is to anticipate the unexpected and make a contingency plan. So a safety net is to be always ready for the future, for the patient, to make a plan. If there is, for example, a patient is going through cancer treatment, you know that their immunity will go down. If there is a pandemic around, or even if there is no pandemic around, they are more liable for infections. Okay? So you have to think in advance. But you also have to think of your own safety. We'll go to housekeeping, your own safety. For example, if it's an infectious disease, whatever. But also take care of your own, as a doctor, your own physical and mental health. So you need to consider your health and safety as well. Can anybody tell me a any examples why the doctor need to think of their, I mean, in all cases you need to do that. نمونه كم أتوانن بيا بدن لشو حالتك دكتورك يعني نمونه بيا بدن أبي بير لسلامتي وتندرسي خوشي بكاتوا شيء وحقل نخوشك عفوا شو Oh yeah, okay. Yeah, why not? As a doctor, you could be there, but this is true for everyone. It's true. Yani, this comes back to first aid. When you're trying to help someone who's drowning, you have to think. I think you are giving it as an example, so you can help somebody, but you have to know how much to help them. Yeah, this is in general, but I want a specific example. Yes. Sorry? Like, okay, what sort of example in cardiologist? Radiology. Oh, okay, sorry, I thought you said cardiology. Okay, yeah, radiology. Why? I think it's obvious. You need to think of your own safety. Yeah, okay. Any other example? Exactly. You have to think. I mean, you're breaking bad news to someone. So you have to think of the patient, but you also think of yourself because you don't know their interaction. Yes, pandemic, you have to think of your personal, protection, all the protection things that you have in the case of any infectious disease, whether pandemic or any other. So infectious disease, you have to be careful, okay? Anything else? I think you... Yeah, contagious diseases, anything else? Any other idea? Any other idea? Okay, I think one of you mentioned it, but I think doctors should also think, for example, in the case of bad news, but generally speaking, especially in our societies where people are more emotional, more liable to get angry, but I think in all societies. Especially if a result of something, a treatment didn't go right or whatever, you have to, and I think we know an example of, that happened here, that the doctor needs to think of their safety as well. أنا اشتكي ما باسكت جاري كنت ما نشك يعني هنا موديول كثير ما نشك زور بلا بطوا بونمنا يعني حتى قالت أوشتانا دكتورة كأبي بيد للسلامة خوي بكاتوا نكلاني ديزيز ولاني أو كسر رنجة توربي رنجة تشكي بيبي تشكشي بينا بيبي أو كسر عقدابي يعني it's not that, it's not only that, but that is another example in addition to the examples you've provided. Okay. So here is, as I said, this is the first model to recognize the importance of self-doctoring, safety nets, safety for the patient and for the doctor, and housekeeping to take care of the doctor himself. I mentioned the word rapport, and you've taken it before, and this means to have a close and harmonious relationship with the patient in this case. So again, we are still with this consultation model. It says that the doctor, when it describes the plan a bit more, the doctor needs to have two ways of thinking going parallel. To be an organizer, to organize a consultation, ask the right exam, plan the treatment, and so on, record things, but also to be a responder. So he has to listen to the patient again and try to be empathic, attentive, think with the patient, and to have, to be creative and have ideas if it's required. Three-function model, this is, depends on, please stop talking. Alright, so this depends on three functions. First, gathering data, understand the patient's problem. To take the information from the patient or the patient relations or from the resources or from the test results and so on. Develop rapport and empathy and respond to the patient's emotions And the third thing is be aware of patients, education, and motivation. So you can see this one, here is the point that differentiated from the other models. يعني أما ويا كاتو زي جواز بينا لما هم ليك كاتو بيبزاني شخالي كواكا أم موديلا تو زي جوازي كان وكانيتر هم بوي بزاني شو موديل زيادة بكاردي هم بو امتحانش يعني بوي تيبقى شون شجورة برسيارك ديتا. Okay, so here it focuses on one of the points is to be aware of the level of education, so how you talk, how you explain things to the patient, how much you take their opinion about the treatment plan and so on, and motivation as well. What is the real reason for the patient to? Sometimes, for example, a patient might have a problem that they are too embarrassed to talk about, but they come and talk to you about another problem. Sometimes patients come there because they are obsessed with going to clinics and visit doctors, and they might not have a real physical problem, or even, not a real physical problem. So you have to be aware of things like that. This caricature just says that patients are very much impressed with good doctors. Doctors who listen to them. It doesn't mean that if you are nice and kind and joking with the patient, but you don't have the right knowledge and you don't care about giving them the right treatment, that's okay. No, you need both. Knowledge, the right knowledge, so a proper doctor in diagnosis and treatment plan, in being a little firm when there is need for that, but in the same time, as I said, listening to the patient and understanding their situation, their lifestyle, anything that might help you in better diagnosis and for them to comply with the treatment plan.